This podcast is for educational purposes only and is not medical advice. For personal medical care, please consult a qualified healthcare professional. This is Dermatology Undressed, a provocative podcast. This episode is Borders, Biology, and the Body. Welcome, I'm Dr. Lindsay Ackerman. While medicine often likes to organize itself into silos and individual body parts or medical subspecialties, today we are intentionally violating the rules, highlighting the intersection of organ systems, the skin, and the female reproductive organs, medical subspecialties, oncology and infectious diseases, and explaining the importance of medical care provided by breaching borders, literally across global regions. The skin, cervix, oncology, infectious diseases, volunteerism in medicine. There's a lot here to unpack because the body does not recognize our silos, nor the resources of our geographic location. In high-resource settings, we often detect cervical cancer and vulvar cancers early. We screen, we vaccinate, we biopsy. But in resource-poor regions, the absence of infrastructure changes everything. What is preventable here becomes devastating elsewhere. Today, we are exploring what happens when dermatology, women's health, infectious diseases, and global inequity intersect. This is Dermatology Undressed, where the skin speaks. Today in different dialects and across borders. I am honored to welcome board-certified dermatologist and global medicine physician volunteer, Dr. Gail Goldstein. She is a practicing clinical dermatologist as well as both a co-founder and board member of the Gynecologic Cancers Research Foundation, whose work has extended far beyond traditional clinic walls. Dr. Goldstein has served marginalized populations across the globe in settings where screening is limited, pathology is scarce, and prevention looks very different than it does in the United States. Dr. Goldstein, welcome to Dermatology Undressed. For listeners who may not fully understand the scope of what you do in volunteer medicine, tell us a little bit about the foundation that you and your husband have founded. You, a dermatologist, and he, a gynecologist, and why? Why was this so important?
Thank you so much for having me. It's a pleasure to be here.
It's a pleasure to have you.
We started our volunteer work internationally about 10 years ago, maybe a little bit longer than that. And initially, we volunteered with other organizations, both in primary care and dermatology, in GYN, until we kind of found what we thought was an unmet need and where we could really help more than just joining in. And so my husband, Andrew, who's a gynecologist, saw the need for basically see and treat cervical cancer screening, HPV testing, and treatment. And we established our own foundation, and we've had many generous donors that help support it. And we've been able to do our work in many countries.
It's amazing. And I hope that everyone listening will go to the Gynecologic Cancers Research Foundation, which you alluded to Andrew's name. So Andrew have founded and co-lead as the board members, as two of the board members, of course, of the organization. I think I'd love to start out because so many of our listeners really don't necessarily know that the critical care that we are delivered here just by virtue of living in the United States is just not readily accessible in so many parts of our globe. And for women's health, this can matter not just because clearly there are easy to screen for cancers like cervical cancer that get omitted through the screening processes that don't exist there, and therefore women really struggle in these communities. But I think moreover also there are cultural changes and sort of nuances to care in other regions that is almost just not considered worthy. So I want to take a step back and just ask, where did your interest really start with serving these populations in low-resource regions? How did you and Andrew become involved? How did you really decide this was a calling for you?
Well, I would say in the beginning of both of our careers, we were really directed on, accomplishing the different goals, the different milestones, medical school, residency, starting our jobs, starting our families, and we didn't really have a lot of time, energy to look outside of that bubble. But then as we became a bit more established, we did, and we wanted to show our kids a little bit of how things are outside of that bubble, outside of our comfortable world. And we made the difficult decision to do a family gap year where we took the kids out of school. We took a pause from our jobs here in the States, and traveled abroad and did this kind of work, both for ourselves and to have a change, but also just to show our kids uh, something different, and so that they could have an appreciation for what you alluded to, what we enjoy in this country, without really much thought about it.
Yeah. I mean, it's really pretty astounding to think that both you and Andrew gave up careers for a year. I mean, that's revenue for a year, the both of you as physicians, and took your children out of school for a year. I'm sure you were, quote unquote, home away from home, schooling them, but to give them this exposure. And I think one of the things I'd love to learn about is, what do you think was the most, surprising thing, when your children got to these other locations or other sites? What do you think astounded them more than anything else from the get-go?
Well, I mean, I won't say that it was all wonderful. I think especially in the very beginning, there was a moment that Andrew and I looked at each other about a month in and said, you know what, we're not too proud to say that this was a mistake, and maybe we need to rethink this. And we stuck it out, and the kids were a little up and down, I would say, in the beginning. But of course, they got a lot of attention, right? So this was a pretty unusual thing at the time, a whole family doing this in other places. Luckily, they spoke Spanish. So when we were in South America, they were able to actually communicate and play with other kids and help in the waiting area and do small projects and things like that. And I think that it was probably for them the first time that they felt truly useful. I mean, aside doing chores at home and things like that, but here they really um, felt that sense of purpose, even as teenagers, and our youngest was only 9 years old. So I think that started to show through, and they started to enjoy it. Obviously, they couldn't do much of the medical work at that time. Since then, they've gotten more involved, and but at that time, it was more relationship building, helping us, helping moms that were coming to see us with their children. And I think it opened their eyes in so many ways. I mean,
And
looking back, they of course say that it was one of the formative experiences, but at the time, it was the same thing: hangry, tired, that kind of stuff.
yeah, for all parents listening, we get that. So let's really talk about what you do. So, in what regions are you doing this work, and what are you doing to change what healthcare looks like for women outside of the United States?
Yeah, so our focus is really on cervical cancer and early intervention. So we do a lot of screening camps, and we do it in different countries. We've worked in um, Peru, in Iquitos, and in the surrounding areas in the Amazon jungle. We've done it in China. We have an ongoing project in Cambodia, and often this is with people who are marginalized within their country. So all of these countries do provide healthcare, but if you're in an ethnic minority, if you're a person living with HIV, if you're in any kind of marginalized group, that care really starts to erode. And we have similar problems here. And so we work with groups that don't have access to traditional care in their countries. We screen for HPV. We identify women who have high risk HPV, and then we do colposcopy to identify any changes in the cervix. We've been working with with a moonshot effort led by the National Cancer Institute to change the protocols for screening and treating for cervical cancer across the world. So we've been part of that program.
And for our listeners to understand, you reference HPV, which is human papillomavirus, which is a viral infection that's transmitted through intercourse. And for both men and women, HPV can be very dangerous. Of course, the cervix being hidden, that's an area where HPV can convert, sort of an HPV infection can convert into cervical cancer. But on human skin, HPV can present as nothing more than just a genital wart. And that's where that overlay of both dermatology and gynecology really intersect. So I would imagine that there's a lot of stigma in some of these cultural, in some of these cultures that precludes women from seeking care or may marginalize them even further within whatever minimal care that they could have pursued otherwise.
Absolutely. We saw, some really tragic cases, and we've seen social situations where either husbands or mother-in-laws or bosses or, prevent women from getting care. We've had to uh, do counseling, intervene, really try to persuade and, make women feel like it's safe to do some of these interventions and even the original examination or testing, So basically, we have teams on the ground that for months before we go and do one of our brigades, will, be promoting the campaign, explaining. We have videos in different languages and all of those things. And then, of course, when we do the brigades, we try to be as discreet and attentive to those types of stigmatizations, especially when we work in the populations living with HIV.
Can you tell me about just a given situation that you may have been surprised by or that came upon you all when you were there in any of these places? Where you really had insight into something you had not imagined, from cultural stigma to fear or an advanced disease burden, anything like that?
Well, we've been working for 5 years in Cambodia. So we've screened more than 5,000 women in Cambodia. And
Wow.
yeah, I mean, the
Wow.
numbers are high. And um, when some of the times that we go, we work in factories. And so what our idea, and actually it was Andrew's idea, was to try to meet women where they are. And a lot of the women in the age group that we screen are working in garment factories, Nike factories, Lululemon, all of those types of things. And so because our screening is so quick, it can be done on a break or at a lunchtime. And it can be done in a makeshift tent or in a lunchroom, things like that. We were able to get
Hashtag
cooperation.
cervical cancer detection over lunch, right? I
Yeah.
mean, that's really what this is. Wow.
Yeah, because really we had to work with factory owners to kind of say, look, how is this going to benefit you without losing any revenue, work time, and all of that? And the way we posed it was that this was a great um, uh, a benefit to their workers, right? So to keep them healthy, but also that it was a good PR moment for these factories to say, look what we're providing for free, right? I mean, we do it for free. We make all the arrangements. All you have to do is let them come by for 15 minutes and we'll, take care of it. So we were able to do a lot in the factories and kind of seeing the inside of these factories, right? Where our things are made. And to realize that those are considered like good jobs. I mean, that's a good job. Um, and it's difficult to watch, right? I mean, it a little bit changes your consumption habits. In fact, one of the factories that we worked in was making the scrubs and the surgical disposable items that we just pull on and pull off, and the gowns that our patients wear for 5 minutes or 10 minutes and then go into the landfill. So, that changes things. But the other group that we work with, many of them are sex workers or sex trafficked, and some of those stories are really difficult. Sometimes we'll identify a woman who needs extra care and we'll reach out and reach out. And we have teams that are doing follow up and we can't reach them. And then a month later, they call and it's because they've been trafficked somewhere. They're working during that period and they don't have their phones. And then, so those types of things are just very difficult for us to understand.
Yeah. I can't imagine. I mean, training here in the United States, we go through such a rigorous program to become a doctor, right? From the pre-medical curriculum to the 4 years of medical school and then an internship, followed by several years of residency. And yet, in so many ways, we're still just so protected. We don't see all of these things and the impact that the absence of the provision of healthcare or cultural stigmatization can have on the general health and well-being of so many of our people. It's just as difficult, and sometimes we say even terrible, healthcare and navigation thereof in the United States can be, you sort of hit the jackpot the day you were born here, in a lot of ways,
It feels that way. I mean, we encountered many women who'd never had a pelvic exam. I mean, they had children. They have had children and they have never had a pelvic exam. So, we learn as we go, right? So we take some things for granted and some things get lost in translation, even though we have teams of translators. But what we've learned is, a lot of videos, of videos that demonstrate exactly what we're going to do, what we want to do, what the whole process is, and that reduces the stress level a lot. And I think that healthcare in the US is very different in that it's more of a relationship. And in a lot of other countries, we see that the doctors just do what they need to do or say what they need to say, and there's not a lot of back and forth. So sometimes the patients aren't really used to asking questions. They're not used to expressing themselves in that way. And so we try to not only see and treat when we're there, but also teach and show sort of our way of doing things to the doctors and nurses and midwives that we work with, on location, I guess.
Yeah. And again, I mean, one of the things I think sometimes you and I probably don't like to hear is that medicine feels transactional. Sometimes people are on a conveyor belt in the United States, but really what you're saying is, and I would agree with you holistically that yes, medicine in the United States is foundationally dependent upon a good patient-physician relationship, first and foremost. And it's anything but transactional. But it sounds like in so many of these countries, maybe that's just the expectation is that there's just a job to be done. And
I think it's a hierarchy, and the patient is, used to kind of just, or they'll just get a piece of paper and no explanation, and they'll just carry the paper around, and that's sort of their, yeah. So,
and so you had mentioned Peru, Cambodia, China, ongoing projects to detect gynecological cancers. I would imagine that you and Andrew and the board have some data in addition to how many women you've touched, how many communities you've been involved in. I would imagine, gosh, how many cancers you've detected. Is there anything that you can tell us about some of that? Or maybe we should just go to your Gynecological Cancer Research Foundation.org to look for more information.
So definitely, we have a website, but we have a ton of publications. So we typically bring a team of doctors and medical students and sometimes pre-med students who are doing research. And after each campaign, they publish. So they'll publish either a study that they initiated, like asking a couple of questions, like how did you, we introduced self-swabbing, right? So to test for HPV, it's a swab, like a Q-tip type of a swab that has to be inserted into the cervix, and then just kind of spun around a few times, and then it's tested, kind of like what we're used to with COVID testing in the nose.
I was going to say a
Same
throat
thing.
swab or a nasal swab. Yeah.
Same thing. And we can get the results, within a few hours. But traditionally, that had always been done by a practitioner, right? A nurse, so then it involves lying down, stirrups, the whole thing. So years ago, we piloted. I don't know if we were the very first, but we were the first to do a large scale one in China with thousands of women, where we taught them in how to do self swabs, and then we asked them the questions like, "How did that work? Did you prefer it?" Some people preferred letting the doctor do everything, right? But for the most part, I think women preferred being able to do that. It's just like one little less injustice, right?
Of
Of having
course.
to, yeah.
Yeah.
So there's a ton that's been published about the different things. And then lately, the Cambodia data is part of this bigger effort by the National Cancer Institute, where they have multiple sites, about 10 sites all over the world. And our Cambodia site was the Asia site. So we always, when we do these studies, we want to get data from different groups, right? Just to make sure that there are no major differences in European versus African versus Asian, et cetera. So we were the Asian site. Now that data, everything was very close to being done. And then there've been these funding cuts and a cessation to some of this international work that the US has been involved in. So we are still working. We were just on a meeting last night, working to complete that last bit of data, not just at our site, but in Malawi and Bolivia and all the different places, to get that complete. And really the idea is to push towards this HPV testing and using the data from the HPV in combination with the data from looking in the colposcope at the actual cervix, combining those two to come up with a risk stratification and treatment. And that's moving away from like the pap smear, which is what,
Yeah.
has been used for so long.
Wow, that is just absolutely incredible. I just want to call out sort of a summation of what I've learned today. And that is, we talked about, borders as sort of an elusive analogy to you crossing borders. But really what you've done is not just taken down the borders of our countries, but eliminated the boundaries for women to seek care by providing the education ahead of time with your teams, giving them insight into what's going to happen so they don't have that boundary of the unknown, to meeting them at their site of work, right? Creating an ease of access. So you eliminate the boundary of them trying to navigate where to go and how to get there to seek screening. And then even moreover, eliminating that sort of boundary of, having to lie down and, feet up in the stirrups and succumb sort of to the natural, again, injustice of what the screening has looked like to allow women the privacy of their own self-swab, capability. And then lastly, hopefully, extrapolating all of these things across a myriad of places where this can be, dealt with in a more humane and fair way for women across the globe. This is amazing work. I mean, this is just absolutely amazing work. And from, a person who, you are a dermatologist, not a gynecologist. Your husband obviously covers that role for your organization. But, coming from someone who doesn't have to do this is not like, you're forwarding your own education by doing this. You're not learning more about dermatology or expanding knowledge per se, quote unquote, to students in dermatology. You're doing this for the well-being of women and access to healthcare along a lane that really crosses both specialties of where skin, dermatology and oncology in gynecology overlap. Hi, I'm Dr. Lindsay Ackerman. Every day in dermatology, we see more than skin. We see early clues, missed signals, and opportunities to diagnose something much bigger. That's what inspired this Skin Tell Agent medical docu-series. Through real patient stories, we follow the moments where something on the skin leads to a deeper diagnosis, sometimes life-changing, sometimes life-saving. If you want to see dermatology in a completely different way, I encourage you to watch. You can watch full episodes from Season 1 and the new Season 2 on Skin Tell Agent's YouTube channel or at skintelagent.org. So I want to transition a little bit into that for, we talked about HPV, the human papillomavirus, the virus that can cause genital warts and can cause cervical cancer in women, can cause oral cancers, can cause genital cancers in men. And we call that squamous cell carcinoma. And that's a common form of skin cancer that we know to be sun-induced many times, squamous cell carcinoma. But again, indeed, HPV can also cause squamous cell carcinoma of different organs. So we talk about the oropharynx or the throat and the tongue or the skin. There are other skin conditions that can predispose as well to malignancies in the vulvar area. And I was hoping you might just, again, with this overlap of skin, dermatology and gynecology, maybe we can talk a little bit about a condition called lichen sclerosus, another condition that, overlaps both specialties and that you may have encountered in your screening.
Yeah, absolutely. So I think lichen sclerosus is an interesting disease. And although you say, yes, it overlaps both specialties because it's often found in the vulva, which is gynecology, but the vulva is skin, which is dermatology. But I would say it's a disease that kind of misses on both specialties. So, not every dermatologist does full exams. And I think that's part patient preference because often women are seeing a gynecologist, so they feel like that area doesn't need to be checked by a dermatologist. And dermatologists are busy and sometimes don't, do that. And it's not a sun exposed area. So sometimes we feel like it falls outside of our purview. Gynecologists don't train very much in vulvar disease. So the vulva is the skin outside of the vagina. They're more trained on, diseases of the cervix, vagina, childbirth, all of those types of
The
things. So
internal, yeah, no man's
internal
land.
part.
It can be
Yeah,
no
so
man's
it
land.
is. It is. And so my husband Andrew really has become a specialist in this area, partly because of our shared interest and partly just because it was a deficiency. And so he is responsible for training, uh, many gynecologists in this area, writing textbooks, articles, etc. And I think it's gotten a lot more attention. I mean, I think through podcasts like this, through lectures, through conferences devoted to vulvar health, women's sexual health, etc., the vulva has, you know, gotten more attention, and rightly so, because 60% of vulvar cancer is caused by lichen sclerosus, and a lot of doctors wouldn't know lichen sclerosus if they saw it.
And I want to pause and just have you reiterate that because I think that is exceptionally important for all of our listeners. I'm just going to assume that 50% of the population listening are women. So potentially impacting 50% of our listeners directly. You said that 60% of vulvar cancer is caused by
Lichen sclerosus.
yeah. So basically an inflammatory disease of the skin that a dermatologist is going to be really adept at diagnosing if they are looking there. And that a gynecologist may just overlook because they're taking the speculum and going inside and doesn't even really actually do a visual inspection of the vulva itself.
And I would say most women don't see a lot of vulvas, right? I mean, most
Oh,
patients know their body, but they're not looking at bodies the way you and I are looking at bodies all day long. So sometimes it's hard to even know what is normal and abnormal. And I think that
yeah.
um, sometimes that's the issue with lichen sclerosus also. I mean, often it's symptomatic and it is brought to the attention of doctors, although patients often have to see multiple doctors before they get a diagnosis, but sometimes they don't even know to ask.
Yeah, and I think sometimes too, so many the bracket of patients that are at risk for lichen sclerosus are usually the postmenopausal female, and many times, literally, I've had women come in and talk about the symptoms they're having, and yeah, well, my PCP just, it's they think it's my menopause, and that's why I'm dry or I'm itchy, and it's not given the attention that it has deserved. But that's also because, like we just said, the vulva has kind of been this no man's land. The fact that it's not a sun-exposed area means not every dermatologist is asking or looking. And because, in gynecology, they're looking right past it to get to the internal organs, which are their expertise, it's left kind of just up to patients to know to say something. And I think that that's really remarkable. 60% of vulvar cancer, that's again the
Which
skin.
vulvar cancer is not our everyday cancer, right?
Of
So
course not.
yeah,
Yeah.
yeah,
No, but that 60% of vulvar cancers are caused by an inflammatory condition called
which
lichen
is
sclerosus.
treatable.
Absolutely. And if it's treated, you actually
Yeah,
greatly diminish the
absolutely.
risk of lichen sclerosus
Yeah.
evolving into a vulvar cancer. And there are other cancers that can involve the tissue space down in the vulva. One, for example, extramammary Paget's disease. I'm just
Hmm.
wondering in your ventures afar, where women don't seek care for gynecological concerns, have you ever encountered either a lichen sclerosus case you think developed
Yeah.
into vulvar cancer or extramammary Paget's disease?
It's funny because when we go abroad, the the diseases are the same, right? I mean, these are the diseases that humans get, but the proportions are totally different. So, like in my practice in Annapolis, Maryland, it's skin cancer, basal cell, squamous cell, melanomas, all day long. When we go abroad, it's not skin cancers anymore. It's
And you
infectious
mean
disease. It's uh,
okay.
yeah,
Sorry, you mean skin cancers of the common type in sun-exposed areas when you say basal
absolutely.
cell,
Yeah, but
squamous
just the
cell?
whole shift of what we see, right, is
Sure.
different when we travel. So basically, because I'm a dermatologist, if a woman is there for her cervical exam but has a skin complaint, they're seeing me anyhow, right? So I'm
Yeah.
seeing more than just the vulva. But yeah, I mean, we see a lot of warts, we see vitiligo, we see uh, uh, scleroderma, you know, all of the diseases, but often more advanced. The doctors that we bring with us on these brigades often tell us that they see more pathology in the time with us than they saw throughout their entire residency. And so they're motivated both to come because they want to help and it feels good, but also they're learning a tremendous amount about pathology while they're with us.
Wow. Yeah. I mean, that says a tremendous amount. And I think it again speaks to that which we take for granted potentially, right? All the screening programs that we have that really matter. And I want to call out as part of that, just even vaccination programs, because in the United States, we now have HPV vaccination programs. Tell me a little bit about what you've encountered abroad as far as that is concerned.
Yeah, so it's just starting up. The vaccination programs in many countries are government, and it's difficult to break into that. So it would be very difficult for us to go and say, "We're here, we have a bunch of vaccinations, we're just going to start vaccinating people." That's really not part of what we can do when we go because that's directed by the government. But the good news is that they are getting on board, and also as prices drop to get these types of vaccinations. um, I think in the future there's going to be an end to cervical cancer. I mean, between a vaccination and these screening programs that will take us until this next generation is vaccinated, we should see an end to this cancer.
That's amazing. And I think for the listeners, too, we should remind them, because I don't know that we've actually said it yet, but cervical cancer is essentially, correct me if I'm wrong, 100% related to HPV infection, a sexually transmitted viral infection. And hence the stigma, most likely, in many of these locations for women to seek care.
Yeah, I don't know. I mean, the stigma of having HPV shouldn't be there, right? Because we know what the numbers are. If you've had sex, then with anyone who's had sex with anyone else, your chances of having this is much higher. I think the stigma in many places is just still around gynecologic care in general, about women's health. I mean, it is
Yeah,
not prioritized.
right.
Yeah, care for
And
women.
right. And unfortunately, I would imagine that, there's an innumerable number of patients of women whose ultimate demise has been, death to
Yeah.
a cancer that otherwise could have been screened for, could have been vaccinated for, could have been totally mitigated had it been addressed earlier.
Yeah, and I think for
Gynecological.
us, that's the saddest thing because our program is really to identify early stage precancerous lesions. We do thermoablation, we do leaps to just cure it, essentially. But if we screen and a woman already has cancer, then it's a whole different ballgame. And that's
Yeah.
the saddest part for us because when we screen, uh, mostly we screen and most women are fine. 10% have high risk HPV. They go on to have some treatment, but then there are those few that come in that already have cancer, and we've been able to provide end of life care for those women, some surgeries, but it's not curative at that point. And so,
Yeah.
our goal is to reach the earlier patients, but you never know who's walking in the door.
Yeah. In some regions, do women require permission to seek care? Have you seen that?
Yeah,
And
we've
from
seen it.
whom?
We've seen it in the Amazon region where women will tell us, well, I can only come on this day or this time when my husband's not around because he doesn't want anyone else to examine me, that type of
Mm-hmm.
thing. But we also see a lot of camaraderie between women where one will tell us what's going on with another or watch someone else's children, etc. But it's hard for us to know exactly what the barriers are, and often there are multiple barriers.
Yeah.
I've worked in places where it's the mother-in-law that kind of calls the shots and decides who needs what and what's going to happen. But yeah, and financial barriers, right? So sometimes it's that they can't get to the clinic. And so we have often provided vouchers or transportation or different. I mean, the barriers are cultural, financial, logistical. It, you
Yeah.
can't imagine the number of
Yeah.
barriers. And for us, it's like, oh, the doctor only works from 8 to 4, and I gotta take off work, and why can't they see me in the evening?
Yeah. I know.
Yes,
Yeah. The
it's a
things, again,
barrier. It's a barrier also, but it's a different barrier.
completely. So
Yeah.
for those of us, physicians listening that practice in high resource environments, the United States, what do you think we take for granted most?
I think that here, um, we don't accept our fate. Like
Mm.
we have this idea that um, we're going to beat the disease. We're going to go to the next expert. We're going to get in the clinical trial. We're not going to stop until we've done everything and have beaten it. And what I see in other places, and I've given it a lot of thought, is just a little bit of a different idea. It's like, this is how it is.
Yeah.
It's not acceptance, and I don't know whether it's religious, cultural, or just worn out. Right? I mean, you could just be worn out, but we don't see. Uh, it's a different approach to life and to healthcare that we see in some patients, not in all.
So you've shared so much about what you do. I'm still like in awe. I really am. All the way
Thank
back
you.
to taking your kids with you and this experience they've had. But tell me, if you would, if you're open to sharing with our audience a patient story that has stayed with you.
So I think we were on the last day of a screening camp, and this was a case that really affected everybody. And sometimes it's always the last woman that comes in, and this was the last woman, and she came with her husband, and she had told us that she hadn't urinated in days. And initially, we do have a urologist that comes with us on these trips, but initially we were like, that's not our thing. We're doing this, da da da. But then through translators, we spoke a little bit more, and um, we agreed to examine her, and she had some records with her. And basically, her cancer had eroded and invaded her ureters, and that's why she wasn't urinating. And she
And
walked in.
the
Yeah.
ureters connect the kidneys to the bladder. It takes the urine from the kidneys down to the bladder. So her cancer had eroded into the ureters.
Or surrounded them and
Yeah,
blocked the
compressed
urine.
them.
And she walked in. She walked in to
Oh
see us.
my
And
goodness.
when we looked at what she'd brought and examined her, we realized that this really was end stage. I mean, by any metric, end stage disease. And we um, kind of grouped up and said, like, she can't walk out of here. Like, her husband needs help. She needs help. So we were able to arrange hospice care for her, which was really
Wow.
outside of what we do and who we know, but we were able to use our medical connections there to kind of arrange things through um, Judy Norman, who's a doctor in Cambodia, and it was very powerful. And so at least we were able to give some ease to her suffering, but she knew her diagnosis when she came in, but she had heard that we were there, and she was like looking for uh, a
Mm.
different answer.
Wow.
Yeah, that
Oh
was,
my
and we
goodness.
just don't see that. We don't see that here.
I guess one of the things I want to know as another, practicing clinician, dermatologist is, has the global work you've done changed you in a way that changes the way you practice medicine?
I think it's made me more empathetic. I think it's made me appreciate the human condition a little bit more. And even here, although we have it all, right? That doesn't mean that people aren't suffering. It doesn't mean that people aren't deeply unhappy, that they don't have um, issues in their family that are just as impactful as other issues. So I think it did give me, a deeper look into humanity. And I don't always have time to get into it with my patients, but as doctors, we have the privilege of hearing things from people that aren't shared with others. And um, look, the human condition is it's difficult. There's a lot of suffering, whether it's um, physical, mental, relationships. So yeah, I think it's opened me a little bit more to that, and to not just getting the job done, which was
Right.
sort of and I think for all of us, right? We're all a little um, motivated in that way.
Yeah, no, I think you're absolutely right that you said it very simply. The human condition is difficult, and it's all perspective and what you're used to or what you know. And you're right. We have this unbelievably amazing privilege to be invited into people's lives every day. And yeah, we don't have time to necessarily unpack everything that may be going on in their world, but something as simple as extending, a hand on someone's knee or looking them in the eyes a certain way and just knowing they're safe and recognizing that, yes, we really do have this incredible privilege to be able to touch lives every day in a meaningful way. And sometimes a lot of that doesn't have to take a ton of time, you
No,
know.
I mean, you know how it is. You could walk in the room and feel what what is going on, right? I mean, we learn
Yeah.
that over time, and um, it doesn't. Yeah,
Yeah. I mean, I
it's a
can't thank
privilege
you
for
enough.
sure.
Yeah. For, really embracing the privilege that you have, the skill set that both you have as a dermatologist and your husband, Andrew, has as a gynecologist, um, taking the time away from your very busy lives and jobs and parental responsibilities to do this work around the world, to extend your knowledge to places that desperately, desperately need access to care. I mean, I don't know if you could choose one thing you would change globally with your Gynecological Cancer Research Foundation work, whether it would be vaccinations, screening infrastructure, education, pathology access. Um, it just seems like you all have done so much in so many of these arenas, and it's changing lives, like literally, quite literally
Mhm.
changing lives, and maybe even bending the curve on cultural stigma and nuance and all of that as well, that goes into ultimately the care that people either have access to or don't. I just want
Yeah,
to
I think
let
so.
you, yeah, close on that. And
Yeah, and
yeah,
I think with improved technology, we've seen the prices of things go down. We've seen the size of the machines. We used to tote around this huge machine that we would like bring in a duffel bag because it cost too much to go through. I don't know who's watching this, but customs and all of those types of things. And now everything is faster, cheaper, smaller. The world is everything's just a little bit easier. And some of these screening programs, I mean, we're talking about $6 a patient,
wow.
$8. I mean, we are at a point where this can be available worldwide. We have the data to show that it's worthwhile, and now it's a matter of governments getting on board, and we're seeing it happen. We're seeing it
Yeah,
happen in Africa and Asia. That a good health minister of a country can make a huge difference.
that's incredible. The precipice of greatness, quite literally. So, I mean, it's so true, though. When we talk about global health, we often speak in statistics, incidence, mortality, screening rates, but really behind every number, it's a person. A person who delayed care because they had to choose between maybe getting food or transportation, or who didn't know where to even find the help, didn't know that their complaint mattered or that it could even be life threatening.
Mhm.
And oftentimes, again, in the no man's land world of vulvar disease or gynecological diseases in other countries, you have a complaint that gets completely dismissed, a disease that was preventable, and ultimately, a death that was avoidable. So, dermatology and gynecological oncology may sit in different clinics, but both exist at the intersection of visibility and vulnerability. The skin, as I like to say, is a storyteller of truths. It doesn't lie, but neither does the inequities that we face around the world. We need to be able to face them head on. I want to thank you so, so much for what you've done, for coming on today to talk about it, and encourage everyone that's listened to go to the Gynecological Cancer Research Foundation. Thank you, Dr. Goldstein, for reminding us that compassionate medicine really has no borders.
Thank you, Lindsay. Thank you for inviting me.
Absolutely. Thank you for listening. This was Dermatology Undressed, a provocative podcast with Dr. Gail Goldstein unveiling the incredible work that she and her husband Andrew do for the Gynecological Cancer Research Foundation. Please go to gynecologicalcancerfoundation.org and explore further the amazing benefits they are bringing to women across the globe. Thank you so much. Like us, subscribe, and share.